Good morning and welcome to the 27th meeting of the Health, Social Care and Sport Committee in 2025. I've received apologies for today's meeting from Sandesh Gohani. The first item on our agenda is for committee to agree to take items 3 and 4 in private. Are members agreed? Thank you. The next item on our agenda is to take oral evidence from the first of 2 panels of witnesses as part of the committee's inquiry into ADHD and ASD pathways and support. And I welcome to committee Glenn Carter, Head of Scotland Office, Royal College of Speech and Language Therapists, Anya Kennedy, Divisional Lead Occupational Therapist, Royal College of Occupational Therapists, Dr Pavan Shreddy, Vice Chair of the Royal College of Psychiatrists in Scotland, and Dr Chris Williams, Vice Chair of the Royal College of General Practitioners Scotland. And we'll move straight to questions, and Brian Whittle.
Thank you, Convener. Good morning to the panel. I'm going to start with you, Anya, because the Royal College of Occupational Therapists had indicated in their submission that investment in early intervention is quite difficult to secure, and you've actually given the example of children and young people's occupational therapy, where the funding for early intervention is ending. I wonder if potentially you can maybe discuss that for us, maybe a bit greater depth, and maybe tell us what the impact of that funding ending might be.
Thank you very much. Well, thank you first of all very much for having me. And the Royal College of Occupational Therapists have rightfully obviously brought this to the attention. So in terms of our input, occupational therapists play a vital role in enabling individuals to live meaningful, fulfilling lives by supporting engagement in everyday activities that they need and want to do. Our profession is deep-rooted in understanding of the interplay between health, environments and occupations, and we're a dedicated workforce that is adaptable and often work across various settings, including health, education and social care and employment. In regards to children's services at the moment, early intervention very much sits within educational environments and working with families, teachers, looking very much at those universal offerings, so how we can support environmental changes and adaptations to be able to support individuals to reach their potential and maximise their ability to engage in school and education. Obviously, by providing support at that really early age when it's really needed in terms of those really key developmental years, we're really supporting children to understand themselves, to understand how the world works around them, and how to manage the different kind of journeys within that. I think that with some of the examples that we can go on to discuss, the key aspect is around those funding for early interventions, that some of the challenges is trying to access some of that funding. But in terms of how we're currently working within existing resources, particularly the child and families, young people and families services, have really some great ways of explaining or sharing skills for adult services. So in terms of how they're offering those across digital resources, across different environments, working with our colleagues, multidisciplinary colleagues, particularly working through our AHP lines, so with our speech and language therapy colleagues, as well as then our medical and primary care colleagues as well. There is an example often occupational therapists work within the child development teams. They also work within the CAM service. And that, in terms of how that is set up, can sometimes create some barriers into early intervention. So what occupational therapists would really like to do is get upstream and be able to access children and be able to access pre-diagnosis. So looking at obviously the importance of diagnosis, but what can we be doing before that? Because often children and families require support long before they actually receive a formal diagnosis. And therefore, what offerings can we provide to support that process so that they're not disengaging in education? We've got lots of key information around the importance of education to children and how that makes them feel part of a community, it builds empathy as well as all those learning experiences. And these are key for engagement further on down the line. So when they then maybe do receive a diagnosis, actually once they feel part of a community and part of that education system and that they have a right to be there, then they're able to often build resilience and coping strategies to support them that may or may not need medical intervention later. So often within our early interventions, what we are aiming to do is to support that pre-diagnostic aspect with regards to understanding for the children, for the families, but also for building those rapports and resilience to move forward through that process. Because as much as we would like that process to be much quicker, and I hope that that's part of what we'll discuss today in terms of diagnosis, the reality of it right now is that it does take a very long time and there are very significant wait lists. And therefore, by getting in earlier and being able to support families pre-diagnosis, we're able to manage some of that and maybe lessen some of the potential challenges that being on a wait list poses to children and to families. Again, early intervention helps that ripple effect. So if you're helping the child earlier, you're also helping the parents, grandparents, siblings, the local community in terms of how you're supporting that. So that very public health message, which is very important for overall health and well-being. And we know there's a lot of inequalities with regards to people experiencing neurodivergence and being able to kind of access general public health services. And in terms of then later in life, you know, if we're able to support that early process in childhood, the hope is then that they maybe need less reliance on services later into maybe adolescence. So, for example, within the CAM services or within your adult mental health, community mental health teams, where we have significant wait lists, again, in terms of all of those processes. So,
Thank you very much. It's a really good start to the discussion today. I think in a lot of that you're describing what you would like to do. I think what we'd like to understand is what the reality is. So, I mean, I'll broaden this out to the whole panel around those barriers to that sort of scenario that you've discussed there. I wonder if anybody else on the panel would like to discuss the barriers to that type of, what we'd call as exemplary treatment, in the way in which we would want our kids to be treated. So I'll open that up if anybody wants to come in on the barriers to that. Just one at a time, yeah.
If I may, I wasn't sure what the etiquette was. I'm Pawan Sredi. I'm a Vice Chair of the Royal College of Psychiatrists in Scotland. And again, I'll start off by thanking the panel for the invite to contribute to the discussion today. I think the barriers are manifold. I think first and foremost is recognizing the sheer scale of what we're discussing, the increase in referral rates, the increase in demand for young people and adults awaiting diagnosis is beyond anything we've ever seen within healthcare systems in recent history, apart from the pandemic. So Spicer's estimate is of a 2,000% increase in referrals in the last 5 years. And that is for people who have been referred into services. We're not talking about people who are struggling, who might not necessarily actually be accessing help, or who might be in school, who might require that support. So I think first and foremost, the barrier is just the sheer number, the sheer scale of what we're talking about. And it's something that has taken services, organizations, policymakers time to realize just how massive the demand is. Our members, our colleagues in the front line have recognized that now for several years, post-pandemic, that steady increase in referral rates, both for children's services but also for adult services. The challenge is then thinking about the system-wide approach to it rather than a specialist service or a healthcare service-based model, which is currently what is in place. So you asked what the reality on the ground is. The reality on the ground is that we have a healthcare model that is designed to meet the needs of 1% of the population, which is trying to meet the needs of about 20% of the population. And that's the reality. And that won't work. It just can't work. So I think firstly, recognizing the scale is a huge challenge. And that allows us to then think about all the tiers that need to be in place, because there is no single solution. It's such a complex issue, and the scale is so massive that the need is for multiple tiers of involvement, which goes across almost all aspects of policy and government. So it's not just for government, it's for local authority, it's for educational providers, higher education providers and employers. What I also wanted to add about early intervention is not just about intervening early in an individual's life. Early intervention is just as applicable if you're an adult. It's just as applicable if you're in your 30s or in your 40s. Early intervention is as much about recognizing it and putting in place those modifications to prevent someone from developing other mental health disorders or presenting in crisis to mental health services with far more significant mental disorders that might require greater intervention. So early intervention can exist in many, many different forms. I work with adult services, and I see a lot of people who have had difficulties for a long time, but there's been a change in the circumstances that has brought these difficulties to the forefront. Or they've had a child who's been diagnosed with autism or ADHD, and that's made them realize that the difficulties they struggled with for many, many years is what they're seeing in these children. Putting in place supports, having access to supports early on, is still early intervention while you're waiting for a diagnosis, and that's partly why we're advocating for a support-first process. Giving access to good quality information, having a Once for Scotland approach to interventions that can make a real tangible difference to functioning is something that can be very, very helpful. And part of that is to do with the nature of neurodevelopmental conditions. Neurodevelopmental conditions are not mental disorders, they're not mental illnesses. These are conditions, these are differences that we live with all our lives. And there's not something that can be fixed or treated and which will go away. And therefore the focus is very much on how you live and adapt to living with these conditions and these difficulties. There are positives to what someone might have in terms of ADHD and ASD, but there are also difficulties associated with it. And that is fundamentally different from a healthcare-based model, which focuses on being well, being ill, and recovery. Whereas here, these are difficulties that are present lifelong, and it's about how you adapt and work. So early intervention is applicable at every stage in the individual's life.
Yes, sir.
Yes, just to add to what Pavan said, I totally agree.
Sorry, Mr. Cap, just before we start, can we perhaps be a bit more concise with our answers, because we've got a lot of questions to ask after this theme. Thank you.
Just agree with what Pavan was saying. I think some of the barriers, if you think about the Christie Commission and the principles outlined quite a long time ago about what needs to happen around public services, it is about prevention, it's about early intervention, it's co-designing and having integrated services. Now, there are some excellent examples in this area across Scotland, but for the majority of the services, it feels like they are stuck in a refer, assess, treat model where we can't possibly meet that demand. And so we're dealing with barriers in terms of services being overwhelmed with demand, and therefore they're increasing their thresholds for how people can access those services, which means people are not getting the support they require. So we've got people in the system asking for help. It can be on a list for many, many years and then may get a diagnosis or not, but also it's the broader support that they're not getting access to, which I'm sure we'll talk about later. And then just to add something to around the adult services, yeah, I think the adult services, there's some learning to be had from children's services in that there's a greater multidisciplinary team within the children's service. We'd love to see more of that in the adult services with allied health professionals like occupational therapists and SLTs fully embedded in those services to give a broad range of support for the people we're trying to serve.
Can I yes, I'll come to Dr. Williams, but just to layer on top of that then, if there's such a huge increase in neurodiversity or conditions, where is the public awareness? Where does that sit within this? And I would imagine that well, the question is, should we have some sort of public awareness, campaign, if you like, for want of a better expression, that if people are coming forward at that pace, where do we sit within that public awareness, Dr. Williams?
So I suppose just covering the barriers aspect, I would absolutely agree with Anya Kennedy's description of how things should be. And of course, where children are in mainstream education, there should be that resource there to be able to have the assessment and the intervention before there's even a diagnosis, and to be working iteratively and so that so that the people who are seeing the children interacting with other children, with the learning activities, are getting the are guiding what's happening. So in part, what I'm saying, general practice shouldn't be an integral part of that. We shouldn't be needing general practitioners to be making interventions, because there should be the sort of fully staffed services. But I guess when we've got our mainstream education under huge pressure, when we have absence from vital roles, especially if there are people spread across multiple schools or multiple areas giving expert input, if you've got gaps there, then there's clearly going to be barriers. So, as with all parts of our health service, sort of staffing resources, can play an issue. I would draw, and there's some very different issues at work in the adult side of things. So, from the adult side of things, there is not the team standing by in the wings, looking to pick up on aspects of their interaction with the environment that is not beneficial, that has gone awry, that is harmful. So our occupational health in this country, for example, is not. I don't think it is not meeting the needs, especially when we've got these emerging mental health concepts that we didn't have 25 years ago, that were not on people's radars. So we've currently got sort of diagnostic formulations that are still, that we're still revisiting. The guidance coming from the NIAIT team, for example, that's a really fabulous example of trying to keep up with the research, trying to keep up with what we know about how people are presenting, when they're presenting, what they're looking for, what works for them in terms of interventions, even before we then get to medications.
I'll leave it there.
Thank you. David Torrance.
Thank you, Convener. Good morning to witnesses. In the view of the witnesses, what should the role of a neurodevelopment assessment be?
Good. Try to start off. I think a neurodevelopmental assessment has many different functions depending on the context in which it's undertaken. And it differs from individual to individual, and that's what we've heard from people with a range of neurodevelopmental conditions. Unfortunately, the current status of services is that an NDC assessment is seen as the gateway for support and for access to input and help and modifications and treatment. We disagree with that current process, and we do not think that an assessment and then a diagnosis should be the only gateway for all of these things. There's an absolute rule for it, but we think that there should be multiple pathways into accessing support, and that the pathway for accessing support should be needs-based rather than deficits-based or a diagnosis-based model. The advantage of having a needs-based approach is that it allows a tailoring of support and intervention based on the individual's needs and circumstances at that point in their life, rather than having a one-size-fits-all where you need a diagnosis to then be able to access anything else. The other unfortunate difficulty with the current structure is that all too often this huge amount of effort placed into the assessment and diagnosis and nothing after that. So actually, if the assessment and diagnosis does not lead to support, it does not fulfill its original function. And that's definitely the case for autism spectrum disorders currently, that for a lot of people, they might wait for a long period of time, get a diagnosis of autism, and then not be able to access support either from education or local authorities or from employers. And that, again, is problematic. But there's also huge benefits for people in terms of undergoing an assessment. It gives them a better understanding of their difficulties. It gives them real meaning to things that they might have struggled with for long periods of time. It gives people access to tools and strategies to better manage their difficulties. But some of those things can happen even without undergoing a full assessment. And that's back to the premise, the question which was about information and awareness. Unfortunately, our view and what we've heard repeatedly is that there's huge amounts of misinformation out there. Most people tend to rely on social media. There was a very, very good study published not that long back which showed just over half of all information on social media is inaccurate, or at times overtly harmful. And actually having greater access to curated, good quality information allows people, gives them the ability to access help and support based on what their needs are at that time. So the two go hand in hand. For a proportion of those individuals, they might then proceed to undergoing a full assessment with a view to getting a diagnosis, and that can be hugely helpful. Another part of the assessment is also in understanding the impact on their life. But usually people come along because they're struggling, because they're finding things difficult. So it's actually about trying to give meaning to that.
Anybody else?
Yeah, I'll go if that's okay. So I think so in particular, thinking about some of the things that have already happened across Scotland with regards to neurodevelopmental assessment is that we have quite a variation in terms of what that looks like. But importantly, the evidence that's come out is to support neurodevelopmental assessment. So rather than having siloed pathways, which we currently often have within children and adolescent services, as well as adult services, is that somebody may be on a list for an autism assessment, somebody may also be on a list for an ADHD assessment. So they may get an autism assessment, but then may have to wait longer for an ADHD assessment. So essentially these systems are inefficient and cause delays for the individuals and their families and their carers. But they also are more not as beneficial in terms of use of resources and skills. So in terms of doing neurodevelopment assessments, the role of that should very much be an integrated pathway, and it should be a kind of one assessment at the right time and at the right place. And I think that that's the important part in terms of when we talk about people accessing, and I agree with Dr. Pravin that in terms of where we come in at this, and it needs to be needs-based, that children and adults should be able to access support under their needs and when they need it, not waiting for a label or a diagnosis. However, in the current system, we do need that in order to gain access to support, particularly within schools, particularly within employments, and it's a layer of protection for maybe an individual. However, moving forward into neuroaffirming practices, and like our colleague mentioned around the committee member mentioned around public information and supporting that understanding of why we need these processes should support that in terms of moving forward. There are, again, kind of challenges with where those assessments sit as well. So in terms of where that role of that assessment, whether that sits in secondary care, which it does, particularly for adult services at the moment. So adults are coming into secondary care, which has very high thresholds for their criteria, given current constraints and other wait lists for other core business in terms of mental health and mental health services. In in children's services, they also have difficult criteria going between maybe pathways that are sitting within the child development teams and then within CAM services, which again is secondary services. So again, it's that kind of stepped care model that we really need to be supporting, where people can access self-help materials, information that's going to support them, so that they can then inform themselves as to whether an assessment and a diagnosis will actually support them going forward. And then it's about them being able to access that in a timely manner, in a neurodevelopmental affirming way, so that we're able to support the individuals to understand themselves, understand what they can do for themselves, as well as support health and well-being.
I think we need to reframe the idea of neurodevelopmental assessment to what people in Scotland want, because what they want is help. Now, diagnosis, of course, is part of the help, and that needs to be acknowledged, but actually, for lots of people, the reason they're driven towards these pathways is because things aren't going so well at home, in school, or in the workplace. And the only place they can see that they can get help is going towards these pathways. And actually, at the moment, for quite a lot of people, they're not getting the support they need, and they don't have access as soon as possible after the concern arises in order to prevent harm in the future. So we do need to think differently about how we frame and where we place resources.
I have no further questions, Convener.
Thank you. Patrick Harvey.
Thank you, Convener. Good morning to the witnesses. It's really to follow up on the same themes, and you know, I've come to this inquiry quite aware of how much I don't know about this topic, and I've been trying to read as much as I can from the evidence that's been submitted. But I still don't know whether, for example, when we're told about the severe delays to getting a diagnosis, I don't know whether that's purely down to capacity or whether it's the result of people wanting a diagnosis where the threshold or the criteria for diagnosis are very marginal. It's a very difficult judgment and they have to be seen many times, or whether it's purely down to the variation in practice between different health boards. And I also don't know, when we're being told by a great many people that diagnosis is an extremely important part of not just understanding their own experience but then addressing it. I don't know whether that is clinically necessary. We've been told these are not disorders, these are not diseases or something to be cured in any sense. This is normal diversity. I don't know whether diagnosis is regarded as clinically necessary here, or is that merely the result of the fact that support isn't available without it, and that it's therefore seen as a necessary hoop to jump through rather than something that's clinically required. Can you answer those questions? Because the evidence that we've seen so far still leaves me none the wiser. Sure.
I might grasp the thistle. And so I suppose that the tricky part is when people, so especially adults, are coming forward to general practice recognising that something is wrong, and sometimes they might have a sense of what it is wrong. And as an example I might give, there are lots of people coming forward as adults whose child has had some neurodevelopmental assessment, and the penny drops, and the parent or relative is sort of recognising in a young person developing something that's akin to what's happened in their life. So there are people who coming forward who have a good sense of what is going on. There are other peoples with all sorts of mental health symptoms and all sorts of life circumstance that then warrant further attention, closer scrutiny. And when we move, so that we've seen a large increase in people from the less severe, the lower severity side of the spectrum, we also still have people who are in the danger zone, as it were, people who might benefit from medication. Mm-hmm. And I guess one of the areas where it's most difficult is trying to reconcile the guidance that we're currently using is based around the specialist diagnosis of conditions, and having that specialist diagnosis as a gateway to the medication, and that specialist diagnosis not just relying upon a few self-assessment questionnaires or a few tick boxes to go through. But actually, it's not historically even just been for the general psychiatrist there. Even within psychiatry, there is a specialism. But so when you've got that as a starting point, then referral pathways start to be built round about that, and then when your specialist service becomes saturated workloads-wise, then the services will find different ways to slim down the waiting list, or different ways to try and prioritise those who might need help the most. And so you get to a point where lots of parts of the service become locked down. From the general practice perspective, we then see lots of people returning to us, either asking, why won't you refer me? And in some cases, we have to say, well, the guidance we have from the health board is that you're not severe enough, or that you don't fit the referral criteria. For other people, we have to acknowledge that they've been waiting far too long, and that we are, as GPs, powerless to influence this. And we can send further updates, we can give advice from outside the specialist setting, but without access to specialists for the most severe, it gets difficult.
I mean, I think it's a very good question about why. The current research evidence around the reasons for the increase in referrals that we've seen over the last 5 years, such as a combination of factors, that there's greater awareness of it, people are talking about it, people are more aware of it, and that prompts people to think about it. There is the likelihood of wider environmental factors, the loss of supports over the pandemic that prompted people to become more aware of these, the frameworks, the structures that we had around us that might have allowed us to cope with these difficulties were stripped away during the pandemic, and all of those factors led to the increase in demand and awareness and the referral rates. The current reality is that the increase has been so massive that all of those factors that you highlighted would mean that the current model just doesn't work. And I'm going to use the analogy of obesity. The current model would equate to everybody with obesity being referred to a specialist gastroenterologist, to see a gastroenterologist in a hospital to be told that they're obese, and then think about all the things that need to happen to help them. We're not suggesting that for obesity, but that's currently what we have in place for neurodiversity, and that is the challenge. And as there is a spectrum for something like obesity, there's a similar spectrum for autism and ADHD, especially. You have individuals who are quite significantly impacted by the neurodevelopmental condition. They have significantly higher rates of suicide, higher rates of premature death as a result of the neurodevelopmental condition, and significantly higher rates of most mental disorders.
Well, I mean, is it arguable that they don't have those experiences because of their neurodevelopmental status, but because of the inability of society to accommodate that, and we hear the phrase neuroaffirming? Can I frame the question differently? If we could imagine Scotland as a neuroaffirming society, would it be one in which diagnosis has the sort of totemic status that it has at the moment?
I think that's an excellent point. And our view is that this is something that we need to think of as a society, about how we support people who are different. This isn't about pathologizing difference. It's about supporting difference and actually thriving, allowing people to thrive. And that wider societal approach is absolutely what is needed. Now, whether that translates into reduction, all of those things, the evidence doesn't exist because those societies don't actually exist as we speak. But there is very good evidence that the stress and distress associated with living with neurodevelopmental differences in day-to-day life, in a society, in an environment that isn't supportive and structured to that, contributes to the increase in a lot of secondary mental health disorders, which would suggest that having a more neuroaffirming society would absolutely have huge benefits for individuals, but also to society. The economic impact of neurodevelopmental conditions is enormous in terms of lost productivity and employment ability.
Thank you.
Thanks, Convener. It's just a quick question. We're talking about diagnosing people. Sometimes there's an overlap. People can have autism and ADHD. So I just wanted to highlight that there isn't just, can't just pigeonhole people into one diagnosis, because there might be overlap. So
if I jump in on that, in fact, there's more than just the overlap. It's about 40% who will have both. So it's a substantial overlap, and that's exactly as Anya said. We are calling for a neurodevelopmental assessment rather than an assessment for ADHD autism, and that is exactly what is recommended by NATE as well. So we need to think about the individual holistically. We have significant concerns about single condition assessments, especially within the private sector. If you look for something, you're more likely to find that, but you're also more likely to miss other things that might mimic these difficulties. And we have real concerns about only ADHD assessments or only autism assessments. And actually what we need to do is assess the individual, think about neurodevelopmental conditions, but also the whole range of other mental health conditions that can present comorbidly. So I'd absolutely agree with that.
Okay, thanks.
Carol Morgan.
Thank you. Thank you, Convener. Good morning. I want to just touch on the variation across Scotland, and many of the submissions, the written submissions that we got, spoke to us about this concern around the level of variation. So I suppose my first question would be, what would be the possible advantages or disadvantages of developing and implementing national standards and pathways across Scotland for neurodevelopmental assessment? I don't know if, do you want to start here? Glenn, thanks.
I think developing national standards would be a good idea. I think the principles would have to be aligned to what I discussed earlier about the Christie Commission, because actually the reality is that people shouldn't need a diagnosis to gain the support they require, and in some areas they don't. So where there's excellent examples of speech language therapy, HP-led services, where Dumfries and Galloway is an excellent example, where they managed to change the refer, assess, treat model to request for assistance, so anybody can phone up and speak to a professional and get support as early as possible. And that the fear was it was going to open the floodgates, and actually that's not what happened, because what they're doing is they're addressing the need as early as possible. That prevents harm over time, and that ensures that we're improving outcomes for people. So guidance about what good looks like would be critical, but we're going to have to think totally differently and embed allied health professions closer to the population. For instance, speech language therapists in education, where you can support these kids as early as possible. You can have conversations with teachers so they're included, they don't develop those behavioural challenges, and that overall we're not driving demand upstream. We need to get further downstream. We need to get further upstream.
Thank you. I think also, I agree with Glenn that having standards would be really helpful in terms of providing that kind of consistent approach across Scotland, because I think we really do have lots of variations, some really great pieces or examples of good work, as Glenn's mentioned, in children's services as well as adult services, and things that we can learn from both services. What I would say is that there's a real difficulty with clear data and the current picture across Scotland, which I think makes it difficult then to measure these standards, because in terms of if we're not reporting, for example, on wait lists or outcomes, then we don't have that data to be able to review and to kind of provide the evidence to show the changes have been made. I think also that in terms of currently adult services, that we have a lot of, so we have standards, core mental health standards, obviously, in the mental health services. We have a lot of neurodivergent people within our adult mental health services already, with and without a diagnosis. So again, a lot of that is hidden in terms of population, because they can be in, for example, adult mental health services, perinatal mental health services, integrated drug and alcohol services, and within the criminal justice service, all of which of these I have occupational therapists working, and I'm very aware of how many people they're working with neurodevelopmental conditions. And I think it's very important, that we look at that as a whole system approach, and really trying to look at the data around that so that we can get a clear picture to make sure that we're targeting and being able to support the populations that we can make the most amount of impact with. Thank you.
I would go a step further and not just say that they're helpful, that they're urgently needed. One of in fact, the key reason for variance within adult services across Scotland is because there are no national standards, there are no nationally agreed pathways, there are no locally agreed pathways for most areas. And that goes back to the point I made earlier, that this was unexpected, this was not something that services actually planned for. Children and young people do have a national service specification for neurodevelopmental pathways. That's hugely welcome. But the elephant in the room for all of this is also funding. Standards are really not helpful in isolation if the required funding to implement these standards is not in place. No service can have an increase in referral rates of around 2,000% and still continue to provide a safe and effective service. And that is the reality the NHS is currently facing. So standards are urgently needed, but the other side of the coin is the resource to implement those standards. Another quick point I also wanted to make was that the standards for pathways and diagnosis and assessment is one element of it. But I think there's also a requirement for a wider national approach in terms of reasonable adjustments within education and employment settings. What constitutes a reasonable adjustment? How do you access that? What might that look like in primary schools and secondary schools, in higher education settings? And that is urgently needed. That's part of the conversation about accessing help first. And that's something else that requires national direction.
Yeah, there are clearly gaps, deficits in it, and this is a national approach may help overcome that, but it will require cross-board working. I'm certain that, and it will require data. It will require some way of collecting, not just that people are waiting to see a specialty, but whether there are certain conditions that we are suspecting or that we are trying to diagnose or receive support for that is as yet unmet need, and to really bring down the extraordinary waits that we're seeing for some people in some parts of the country.
Okay. I mean, I had a couple of questions that I think they've been answered just by that general question. I suppose, just to be clear, from earlier answers, are people agreeing that a single condition assessment would not be the right approach for children or adults? Is that what you said? Yeah, no, that I thought I'd pick that up. And then I suppose my last question, just quickly, is the sort of recommendations by NAE around adoption of standard adult neurodevelopment specification. Are there some barriers to that, or are people feeling that that is something that should go ahead and could go ahead? Do you want to come in?
I'm not quite sure I understood the question.
So are there any barriers to the development and adoption of a standard adult neurodevelopment specification as recommended by NATE? I suppose we're just trying to explore that.
I think it's flagged that the resource is going to be a barrier, and especially if you are using relying upon staff having a specialist area of knowledge or specialist skills, or working together as part of a multidisciplinary team. Do we know where the boundaries are? Can we define the roles of different professions within a team? I think we can. I think there's areas of good practice, but if somebody defines that clear gold standard model, can we fund it adequately?
Yeah, no, that's helpful. Thank you very much. Thank you.
Elena Whittam.
Thanks. And good morning to everyone. I want to explore the concept of a multidisciplinary team approach to neurodevelopmental assessments. And we've already spoken this morning a little bit about how we really have a medical model at the moment and how that is actually really creating bottlenecks in the system everywhere. So I'm wondering if we can first start off with just understanding what exactly are the barriers just now from actually implementing multidisciplinary teams to undertake those assessments and the creation of pathways in that respect. So if we can think about it in the widest sense of everybody that's involved in the care of an individual actually coming together to do those types of assessments. What are the big barriers?
Complete resource. There are around 60,000 people on the waiting list for neurodevelopmental assessment across the country. That is an enormous number. The level of resource required to undertake those assessments currently does not, and I don't just mean financial resource, I mean the workforce just does not exist. I work in Glasgow and there are about 8,000 adults waiting on the waiting list. The resource required to undertake those assessments would be more than the combined mental health resource for mental health, secondary care mental health services in GGNC right now. So that is the scale of the resource that is required. I think first and foremost, that's the starting point that I think it might be helpful. The second is that in the absence of pathways, it's impossible to create those structures. The structures we have are within specialist services or downstream within primary care, and we have a very clear divide in the way our health service is structured. But the point I've made earlier is this isn't an issue for a health service. this is a societal issue, and it is about how we shift that balance into thinking about a much wider approach through education, through employment. Chris made the point about occupational health. Our occupational health structures aren't designed for a condition that is so ubiquitously present. So the barriers are manifold structurally across every element of our society, not just our health service.
So how do we start to build something then that looks at each individual and their role within their own setting? So if we think about all of our allied health professionals, if we think about our colleagues in general practice, and we think about those that have the psychiatry specialisms, etc., how do we ensure that those teams really do come together in a multidisciplinary way to actually affect change in this area? Because it feels as if that's where we need to get to, but it feels like such a long way to get from where we are at the moment to actually realising the potential of such empowered teams. And I do know that resource is a huge part of that. But I think it would be helpful for us to understand how could each of those roles actually come together to create a meaningful change for people.
I think clearly part of the challenge is that teams are firefighting, they've got their heads down and they're trying to manage all the demand that's coming, so we do need to think totally differently about this. I think your point is an important one. Part of this is about strong leadership and being courageous and taking a risk to do something differently. So Lanarkshire is a great example of that, where they've got a multidisciplinary team, allied health professional-led speech and language therapy, where you can have nurses, dietitians, speech and language therapy, OTs, all going into schools where there's particularly high demand, working together very effectively. But they're not only there to manage the diagnosis, but they're there to offer support around whatever the challenge would be for that particular child, whether that's sleep or diet or inclusion within education. But they're working effectively as a team. Of course, they have to work with education and not cause unintended consequences by doing that. But I think that's just a really good example of how that can work, but requiring that leadership, strong leadership and willingness to take a risk and be courageous to do something differently.
I think that's really helpful to have that on the record and talking about that specific example, because if we do think about the associated issues in terms of diet or sleep, those co-occurring issues that can happen for somebody who's neurodivergent is significant to those families and to that individual. So actually not having to try and figure out how you are referring, or having the GP actually be the person that's trying to figure out where to point the family or the individual to, that actual type of team working, I suppose, could be something that actually can make a massive difference to individuals and families.
Yeah.
Does anybody else have any thoughts on that?
So I think you'll be aware of the work that was obviously done with NATE, and we had the Test to Change sites. So we had 5 within children's services, and we had 4 within adult services. So these were great opportunities to be able to look at working differently and how we could roll that out. And alongside that, even with the test sites, there were also smaller projects or smaller pieces of work that were then taken forward. I work in NHS Grampian, and our adult autism team they're an AHP-led service, and their clinical lead is an occupational therapist, and that's really allowed for them to provide very holistic assessment. It also doesn't sit within secondary care, it doesn't sit within the community mental health teams, it sits separate to that, kind of within kind of tertiary care, so in between primary and secondary, so that they are able to support individuals to have a really neuroaffirming diagnostic pathway. The barriers to that absolutely are resource, that they are tiny teams, and often the funding that we have had has been then temporary. So trying to then, we do have lots of, I think, as allied health professions, as occupational therapists, we have a very dedicated workforce who are very keen to support and progress the development of these services and to support individuals. But it's when we have temporary funding, some of those challenges come with trying to sustain that over a period of time, because we're only able to offer maybe temporary contracts. For many people, that's not possible due to their own personal circumstances or also challenges. So it's again how we are able to support the workforce to progress into these areas. Again, that real allied health professional support and working differently within our resources. We are a limited resource often within our services, but we really are that doing part and the kind of living part, which is really supporting individuals to progress and to manage their own health conditions, which is really important when we're talking about neurodevelopmental services, because it is a lifelong condition. And therefore, it's often those things, sleep, food intake, all of those things that are all manageable for an individual in terms of self-management, but it's the long-term effects of that over a course of time that then impact on negative health outcomes. So then that brings in other health complications. And we know that with this population, there's a lot of health inequalities. Yeah. And it's that real importance for how we can then support them earlier and at the right time so that we can then improve overall health and well-being for these populations.
Okay, and I guess the last question I have in this specific area is round about what role does the private sector and indeed the third sector have in terms of developmental assessment? We know that there's pockets of really good practice across the country where the third sector is absolutely involved. We know that some health boards are actually involving the private sector in their assessment by trusted companies that do some of that work for them. Is there a role for them within multidisciplinary teams? Yeah, Chris.
I suppose I might firstly highlight potential pitfalls with the private sector, especially around about in the context of long waiting lists and people either feeling harm for being on a waiting list and not progressing or fearing harm. And so we know that there are many private providers who advertise services. Some have physical bases in Scotland. But I suppose and those services have some governance by Healthcare Improvements Scotland. But I fear, especially for operators that are doing things virtually, who don't have a physical base in Scotland, that they can then evade that scrutiny. Even then, so even for providers who are based in Scotland, I would highlight a difference between the NHS to NHS relationship that has historically existed, where where there's a clear knowledge of that there are good governance structures there, that there are ways of ensuring that everything is working just so. And Pavan highlighted earlier the single condition assessment. So if as a patient or a parent of a patient who's desperately seeking an answer and who's paying to seek that answer and paying money to a private clinic that is set up to provide a single answer, then for me there's risk, especially in light of what we've discussed about overlapping conditions, about looking for a range of different possible things that are going on from a mental health perspective. So I don't think that we've found so I'm glad to hear that there are health boards that are using specific providers to give extra capacity, but I know that there's a lot of providers out there that aren't linked in the same way. And from a general practice perspective, we can see people returning to general practice, having seen a private provider, thinking that now that they have a diagnosis in writing, that will either bump them up the NHS waiting list because they've got an extra step that other people haven't, or I suppose worse, that they come with having received a diagnosis privately, with the expectation that the NHS will then be able to start them on a medication, for example, where they're not yet into the specialist service. So there are examples where people are paying for certain circumstances, where expectations are getting raised, but that hasn't changed the gaps in the underlying NHS infrastructure. So I think there's definitely further work to support people round about that.
Yeah, I think the kind of thrust of my question was more around about those trusted providers that have been working hand in glove with local board areas, and also the trusted third sector partners that have also been working very closely. But absolutely here, loud and clear, the difficulties with shared care and the difficulties with assessment in the private sector, where there's not the safeguarding round about the robustness of the services that are maybe being offered and the difficulties that can present to general practice. I don't know if anybody else wants to say anything before I hand back to the...
That's okay. I think I completely agree with that. I think in terms of private sector, I think it's very much around the governance, and it's around the assurances that and safeguarding aspects around quality and what we would be looking at in terms of any assessment tools, in terms of developmental history, and that they were then done in a multidisciplinary way, again, not a uni profession. So I think there's ways, and there are examples of how that works well across Scotland as well as in England, but I think it needs regulation. So I would certainly call for that. But also I think just on our third sector colleagues, they are absolutely, and I do call them colleagues because they're absolutely essential to what we currently do. A lot of what is provided currently is through the third sector, particularly in terms of post-diagnostic work. They also have a lot of people who identify as neurodivergent or have lived experience, and I think that is essential in terms of how we progress working together and moving those services forward, because they come with that knowledge and skills that we can't learn. You can't learn. It's something that you've experienced and that you experience on a daily basis. So I think one of the challenges with the third sector is just, again, that temporary aspect of their funding, and so often they lose funding and I mean, they do an amazing amount of work on a very, very short or small budget. And again, I just really like to call out the amazing work that is going on across Scotland with the third sector. So I think it's really essential to acknowledge that.
Thank you. Thanks, Convener.
Paul Sweeney.
Thank you, Convener, and thanks to members of the panel. It has been really insightful to hear your contributions so far in terms of some of the absurdities of the current system and how it militates against good patient outcomes and good outcomes for public resources. I think one of the recurring themes that we tend to observe as a committee is a disconnect between national priorities for the healthcare system and localised funding decisions that are made by integration joint boards and health and social care partnerships regarding funding for autism and ADHD services. So just wondered if there were any insights or recommendations or perhaps wisdom from your own professional experience about how we might get to an organisational situation where local services have stable funding, but also funding that is modelled to support good patient outcomes and better utilisation of public resources based on the current inefficient model. What would you suggest we do to improve it?
I think one of the challenges with the current structures is that mental health service provision and planning is hugely fragmented. One of the unintended consequences of health and social care integration has been the fragmentation of mental health service provision. Responsibility is split between boards and IJBs. I work in Glasgow. We have 7 IJBs that link into Greater Glasgow Health Board, and coordination of service provision across such a fragmented landscape is incredibly difficult. That is even harder when you have something that is relatively new, that is unprecedented in its scale, and to then get consensus in getting very, very different organizations to agree on funding models and planning. It's virtually impossible, and that is the reality our members have highlighted to us repeatedly. And what that translates into is, I think, a recognition across the board of things that can be helpful, but inability to plan strategically and implement that because of those organizational structures that actively work against such strategic planning processes. One of the key gaps around accountability is the mismatch that you had highlighted about national priorities and local funding decisions. So things like national standards and nationally agreed pathways can help with that if that's supported by appropriate accountability in delivery. That is amplified further around funding decisions, where the allocation to the board for a mental health budget is then very much up to the board to decide how it's spent. And what we've highlighted repeatedly is the huge variance in mental health spending budgets from board to board. There's significant variation in how much is spent on mental health services at a board level, and that variation is not accounted by differences in population need, but it's very much about that local differences. So I think first and foremost, having nationally agreed pathways and standards can go a long, long way in acting as levers for change at a local level.
Thank you, Dr. Shreddy. Is there any other comments from the panel on this issue and what perhaps you would like to see in terms of organisational improvement?
Thanks. I think just a broader point about funding and how to manage the local relationships. We've just published a report in conjunction with COSLA, the Directors of Allied Health Professions and the Association of Directors of Education, about not just how you transform those children's services, which includes services for children with NDD, but also how you manage the funding relationships. And I think that's critical, because sometimes when there's a shared responsibility here, people start falling out with each other. That fractures local relationship, and that's bad for outcomes for local people. So there's principles in there that are helpful around transparency, around decision-making, building local trust, and shared responsibility. So it is about facilitating joint accountability, because this topic we've discussed absolutely is a joint responsibility, and there's a risk sometimes when, for instance, education or local authorities feel the NHS is asking them to do lots and lots of work on this, and then there's the other side of the coin where it feels like education asking the NHS to do lots of things. So it's about finding joint responsibility and a way forward, which is absolutely possible, because we have seen that done in certain areas of Scotland.
Okay, what areas have you seen it done where it's good?
Well, so one example of that would be within NHS Forth Valley, where they focused on what the needs were. It was within children's services, what were the needs for children, how do we ensure these children are safe, healthy, achieving, etc. And then stopped to listen to the population, co-designed it, and then once they had the answer to that question, they pooled their funding and delivered on what the answer to that was. But that was about co-designing, and was a really effective way of doing it.
Just wonder if anyone else on the panel had anything to say on this issue and funding optimisation and organisation.
I was just going to add to that I think we're very much speaking about a hidden population. We're not, boards and IGBs are not having to report on wait list numbers, for example, so it's quite a hidden population. So there's no accountability in terms of what we're doing with people who are sitting on a wait list. So it comes, in terms of how we link from the national priorities down to kind of that local level. There needs to be a reporting structure that then allows for escalation, but also allows for accountability as to, kind of what is being done about, kind of these services.
Yeah, I might again come back on the referrals and the data side of things. If boards are using specific or stipulating specific criteria that must be met for a referral to be accepted, then I'm hoping that that's all being fed back, so that somebody is seeing what level of demand is being turned away, what referrals are being placed on behalf of patients that boards for various reasons are not taking on board, are not looking after. And again, I would come back to the occupation, the role of the employers in wider society, round about, I guess, some of the more low-level activity and problems that people encounter as an employee in the workplace, and the importance of trying to pick that up and to consider about our health in the workplace.
Thank you very much.
Thank you, Mr. Sweeney. Patrick Harvey.
Thank you, Convener. I was going to try and get a supplementary on the questions that Eleanor Whittam was putting to Dr. Williams. So I'm sorry for dragging you back to that previous answer. It was about the role of assessment and diagnosis in the private or third sectors. It seemed to me that your answer quite accurately described the problem, but I couldn't quite get a sense of what you think the solution to that is. Clearly, we have unfairness and frustration being expressed in relation to the financial unfairness. Some people can make the choice to go private, others are being forced into debt, and others feel a desperation because they can't do that, and a sense of frustration because they're not getting the same responses from different GPs about whether diagnoses are accepted and acted on. Are you saying that the solution to that is to restrict or to prohibit diagnoses in the private sector that don't reach a certain standard and then to accept all those that do, or that the solution is only to expand capacity in the NHS. Where do we go from here?
So, I suppose in direct answer to, I'll start at the end. In general, I don't think general practices are in a good place to be able to recognise what is a gold level of assessment, and I think we certainly might see some assessments where we're less certain that a comprehensive assessment has been carried out. That we might be able to see that the letter indicates that somebody hasn't been seen in person, or that there's been a video link to somewhere in London for an assessment. And it's those who are from socio-economically deprived backgrounds who I think are then even more disadvantaged by this situation. And I might highlight the phrase shared care, which is sometimes misunderstood because shared care sounds inherently like a good thing. But what it describes is a shared responsibility. And historically, that has allowed some specialist services to run very efficiently, because general practice is mopping up some of the risk, is involved in organising blood tests or checking pulse or blood pressure, or measurements that it would be difficult in areas like Highland, for example, for somebody to travel to a psychiatric hospital to get a pulse and blood pressure taken. That's not a good use of everybody's time. But in terms of how getting back to the resourcing, how things are funded, so in the past, shared care arrangements would exist for various high-risk medications and would be accepted by general practice.
Forgive me, I'm aware that we're short of time, and I don't mean to be kind of pushing back too strongly, but it does still feel as though this is a description of the current state of affairs rather than a path forward. Is there the potential for a change that GPs would accept and would have a consistent approach to dealing with those who've perhaps gone to the voluntary sector, and a clear sense of what it is that would require, what standard would require to be met in order to have acceptance by GPs in a more consistent way?
So I think if there was a healthy relationship with certain clinics where we understood that there was a sufficient level of governance, where we were confident that that there was a wide range of mental health conditions being considered as part of the assessment, that it wasn't simply a service that was taking money to put words on a bit of paper that matched the expectations of somebody who's responded to an advert, for example. So I think that there would be circumstances in which GPs could be far more trusting of advice that's coming in to them that isn't from their local NHS resource.
Okay, thank you.
And Emma Harper.
Thanks, Convener. Just to pick up on the shared care type of approach, does there need to be a Once for Scotland approach? Like you talked about governance, Dr Williams, and good practice, national guidelines, national approach. So is that the way that we need to move forward if we're going to have this kind of shared model where private is supporting, or vice versa, NHS is supporting the private healthcare system? So
under the current GMS arrangements, shared care isn't a funded arrangements, but yes, there are examples where there are nationally funded bits of activity where things can be done in a standard to a certain standard, and that patients can benefit.
Yes.
I echo everything Dr. Williams has said about concerns around the quality of assessments undertaken in the private sector and the lack of regulation. Ultimately, if an individual, a person, is going to get an assessment from the private sector, I think I deserve to know that I'm having a good quality assessment to the same level as what I would get within the NHS. And I would deserve to know that the person undertaking the assessment has the right qualifications, has the right training, and is the right person to undertake that assessment. So I think there's a need for robust regulation, and our view is that at present the regulation isn't robust enough because of the gaps that Dr. Williams has highlighted, that the current regulatory mechanism does not cover virtual assessments where the service can be based out with Scotland. And actually, that's a large proportion of assessments that are currently undertaken, especially post-COVID, and that is a huge gap. That leads to concerns about the quality of the assessment. That leads to the concerns that Dr. Williams has highlighted, where, as a general practitioner, they might not be in a position to determine whether that is an accurate assessment or whether it's a safe assessment. And I think that leads to huge problems. And that's something that's been highlighted repeatedly. There's also a lack of consistency in what constitutes a good quality assessment, a neurodevelopmental assessment. But we have those standards individually within board areas, but there's nothing nationally which determines what a minimum good quality assessment would look like. And I think that's something we would strongly advocate and recommend. And that can serve as the gold standard of what you would expect, no matter whether it's a private or an NHS assessment. And that's, if I'm someone who lives in Highland or Glasgow or Edinburgh, I should be expecting the same quality assessment irrespective of where I access that. I think that is something that is helpful. And ultimately, the increase in assessments within the private sector are simply a consequence of the lengthy waits that we have within the NHS. And that is the core of the issue. If someone's having to wait 7 years, 8 years, if I'm a 17-year-old starting university and I'm told that I'll get my assessment in 7 years' time, I'm going to lose that opportunity to gain an education and perform well, and it's going to have a long-lasting impact on the trajectory my life is going to take. And that is where people feel desperate to access services and assessments in the private sector. So it's not a criticism of the private sector, but I think it's reflecting the reality of where we're sitting. And ultimately, the longer-term sustainable goal is everything we've discussed previously, which is about increasing capacity within the NHS, about having a wider model that provides support first rather than focusing on diagnosis.
Just very briefly, you said Healthcare Improvement Scotland, where I suppose the governance checking of who's doing assessments, but not everybody is linked with being, I suppose, validated in terms of good practice. So Healthcare Improvement Scotland would be a way to make sure that governance and good practice is widespread across the whole of Scotland.
Could I just comment on that? So, obviously we use guidelines, so we have signed guidelines. So there is signed guidelines for ADHD, and for a long time, I think NATE have also requested that they be reviewed. And I think within those side guidelines, it states appropriately trained practitioner, which is obviously a very broad term. It doesn't identify professions or registrations or expected training. Which I think that brings in some of the confusion then as to the private sector, because there isn't that kind of guidance as to who should be doing these assessments, who is qualified to do these assessments, and then there's the assurance aspect around that as well in terms of individual practitioners. And again, we would really encourage that even if it was to be looked at within the private sector, it would be a really multidisciplinary approach, that it shouldn't be a uni profession, a doctor or a lone AHP doing that assessment, because it is a very multi-dimensional assessment looking at different areas. So that would then be what we would be kind of calling for. You asked about Ones for Scotland approaches, and I think that that has its real benefits. We don't have huge, endless amounts of resources, and we're currently trying to work smarter across some of the resources that we do have. And certainly I'm aware of some projects, so there's particularly a digital resource group that is a working group that is AHP led, and they're working with NES to provide digital resources for people with ADHD in particular, but there are also neurodevelopmental conditions and resources support around that, and obviously NATE have produced a lot of things as well. So again, it's trying to work smarter with what resources that we do have, and by doing a Once for Scotland approach for certain parts of that, we're then able to pull on some of these resources from the skills across Scotland, not just individual board areas.
Okay, thanks.
And a very final brief supplementary from Elena Whittam.
Yeah, I will be brief. It's just several times it was made mention about assessments being done online as maybe not being robust. And I just want to explore that, challenge that a little bit, considering that we do have close to me where we have a lot of people who access services in terms of psychological support for addictions, but also that some of the trusted partners that the NHS do use do assessments online that take 5-6 hours at a time and over several periods. So it's just to have a response to that, because I heard it several times.
So, I'm in no way suggesting that an online assessment is not robust, quite the opposite. It's the person undertaking the assessment who needs to have the right skills. So it's who is undertaking the assessment rather than how it's undertaken. I think the point I was highlighting was the lack of regulation for online assessment being undertaken by service providers who are not based in Scotland. HIS cannot cover them and does not cover them because of the regulatory process. And therefore, it's impossible to know about the regulation and the quality of the assessment that's undertaken. Physically, that might be the same as someone travelling elsewhere and undertaking the assessment with the same person, but it's because of the increase in online assessments that has increased access to these remote assessments by providers not physically based in Scotland out with a regulatory context. There are a substantial number of providers in Scotland who provide excellent quality online assessments, which are no different from a face-to-face. And within NHS, we routinely provide online assessments and virtual assessments. In Highland, that is a reality. It improves access, and it's hugely helpful in actually improving access to services. So I would want to clarify that.
Thank you. Thank you very much for that. That's helpful.
Thank you. Can I thank the witnesses for their evidence this morning? It's been very helpful to the committee, and I'm going to briefly suspend for a change of witnesses.
Thank you.
We will continue our previous agenda item by taking oral evidence from a second panel of witnesses as part of the committee's inquiry into ADHD and ASD pathways and support. And I welcome to the committee Thelma Bowers, Head of Mental Health Services, NHS Ayrshire and Arran, Louise Bussell, Board Director, NHS Highland, who joins us online, Dr Jill Kidd, Consultant Clinical Psychologist, Child Heads of Psychology Services, and Dr Kath Malone, Consultant Clinical Psychologist and Lead Clinician, Tayside Adult Autism Consultancy Team, NHS Tayside. And we'll move straight to questions, and Patrick Harvey.
Good morning to our new panel of witnesses. We've heard, as you'll be aware, quite a lot of evidence about the variation in waiting times in service provision, but also in the various timescales and so on for referrals, pathways to access services and service provision across different parts of Scotland. Can you give us a sense of to what extent that variation is in itself fundamentally a problem, or is variation simply something that we should live with in a country with multiple different health boards providing services to their different priorities? What could the Scottish Government do if it chooses to reduce or eliminate that variation and establish a standard universal set of expectations that people can have? And do health boards at the moment look at each other's performance and treat that as any kind of informal sense of what they need to be aspiring to? Is there any kind of level of trying to achieve not universality but some kind of common expectations at all at the moment? Happy to open that up to whoever would like to kick off. Yeah.
Absolutely. I think the committee has heard from various other colleagues, third sector, people with lived experience, and I think the massive response to that question of variation is that there should not be a postcode lottery. This is a public health issue that should be addressed at a societal level. What does that mean then as a whole system? Partners, organisations within our system, within our communities, in terms of variation and what happens between board areas. As you will have heard, we don't have a performance dashboard, we don't have standards that we can report on nationally. However, I'm completely sure and confident that every board area is trying to collate this data where they can for both children and adults. Certainly that's the case in Ayrshire and Arran, and we regularly connect with other board areas through our heads of psychology services, through psychiatry, through our allied health professional leads, but also through NATE, and just looking at the good practice and learning from where there have been pilots that have taken place. So it's really a journey in that respect. So it's starting to grow the data, the information, gathering information from people with lived experience, and then connecting together to see where it's working and sharing those areas of good practice as well as challenge. In terms of what to do next, we need to build on that, and I'm sure that'll be part of the other questions that you want to go into more detail about, but I think it's really building on the good practice and recognising that we are going to need investment to be able to do that. But certainly, I think we would expect there to be a phased approach to that within our services.
Anybody else want to come in and just maybe react to what we've just heard? The idea of building on good practice. Is that a reasonable phrase to use when practice is so widely varied, and some health boards simply don't provide adult assessments at all, for example, whereas others do?
Yeah, so I was going to pick up on the point around NATE. So they're a fantastic organisation who is bringing together different services across Scotland. So they host quarterly meetings with different health boards where people do come together, different representatives from different organisations to share good practice.
And I think to your question of do we need universal standards or do we need local variation, I think we need both. So I think we need a standard of practice that is consistent across Scotland with local signature. So to be able to be responsive to local need as well as offering a standard that you would expect across. In terms of why that's so inconsistent across Scotland, there's a multitude of different reasons for that, I think. A lot of the points that you've discussed over the past couple of weeks have come down to funding, and that's not undeniable, but it's also about how the resources are used in different ways. So the NATE recommendations around neurodevelopmental pathways, I think, are absolutely the way forward. In NHS Tayside, we have separate services around autism and ADHD, but also working together for a whole-scale neurodevelopmental pathway redesign, which allows for that universal good practice to be implemented with the local signatures as well.
I suppose for children's services, the variation has happened, in combination with the rise in the demand, but also how services were set up pre-COVID and pre that kind of rise. So we know that all services are not set up equally. So we had different pathways for autism and ADHD that aren't able to then kind of meet the demand coming forward. As we've kind of the last few years, we've learned that actually we need to look at ADHD and autism together to stop children kind of bouncing between different kind of pathways and services. So we have, I suppose, the capacity is not easily accessible and it's not co-located and it's not joined up. So in some health boards, it'll be split across different kind of directorates and different kind of children's services or CAMs. So it's not easy to kind of join that up clinically. The other side of that is that some of that capacity sits within CAMs and the waiting list sit within CAMs. So we have this kind of tension between delivering on the mental health waiting list as well as trying to meet the new developmental needs. So we have a kind of we have the skills and the clinicians within CAMs who can deliver that, but actually they don't have the capacity to do that because they're trying to meet the kind of government standards around kind of mental health as well. So the variation has been we know that there's a kind of combination of the demand and then how services were set up, and we need a transformation of how services are kind of configured really in order to meet that demand. And I suppose the answer isn't purely to resource the waiting list. It's about resourcing the system of support around that, and that can look different. I think we've talked about public health approach, so maybe thinking about that kind of national framework that we need, where parents and professionals and education can access kind of resources and support at a national level, and then that also matched with what then is delivered at a local level. So we have areas of good practice where we have consultations that are available for parents and education to phone up at a kind of local level to get that understanding of that child and that kind of formulation needs-based approach without the need for a diagnosis. So I think there are some really good frameworks that we could look at, and also kind of drawing on some of the work around the trauma-informed practice, where NES have that, thinking about the skills and the competencies that are needed in order to deliver a trauma-informed service. How do we develop that for ND? How do we know what we need at a skilled level through to what we need at a specialist level, and how do we have the kind of training to support the kind of skills development?
I think probably everybody's mentioned resources, and it is unavoidable. But if we can acknowledge that, and I'll ask, beyond that, are there any other barriers that you think we need to be aware of in relation either to delivering the NATE recommendations that witnesses have spoken about, or the specification for children and young people that Dr. Kidd has talked about?
I think workforce challenges, historically, although this is a public health issue of health-seeking diagnosis, it's historically sat within mental health services because that's where all the skills and expertise lies. we're aware that we've got a gap in our workforce, psychology, psychiatry, allied health professionals, and services have been seeking to continue to develop those services where opportunity lies. So in Ayrshire and Arran, we've got some variation there because there's a dedicated NeuroCAM service that was established with funding through the Enhanced Mental Health Outcome Bundle. But in adult services, obviously, which is primarily our community mental health teams, those services have redesigned to try to respond to growing demand from a core mental health perspective, and have absorbed diagnostic provision universally to the whole population. Unfortunately now, because that demand is so high, that's where obviously the challenges lie in being able to deliver a diagnosis and prioritise to those people with a mental health need. So I think there's something there of a barrier around workforce, and looking at our national workforce plan, because it's a public health issue. How then do we align our existing workforce and expertise across the whole system? So that's not just mental health, that lies with education, third and independent sector. And what can we do and deliver as a whole society, at those different levels to grow that expertise?
Were you looking to come back in?
Yeah, I was going to say another big barrier is how we shift from our current model to a more whole-scale neurodevelopmental pathway, because the very kind of traditional model of a kind of referral for assessment has led to the huge waits at the moment. And so in Tayside, we're trying to move towards the neurodevelopmental pathway redesign while still tackling the long waits and how to utilise and use the resource in a way that enables the move to a neurodevelopmental pathway design, but completes the task of those who are already on the waiting list.
Okay. I'm conscious that we've got
to come in.
Sorry?
Louise Bossell wanted to.
Yes, I was just going to say I'm conscious we've got an online witness from NHS Highland who may want to reflect on what's been said, but also on the experience of the Pathfinder programme.
Okay, can you hear me okay?
Absolutely.
Fantastic, thank you. And I just wanted to go back a step from what you were talking about in terms of the original question around consistency. And just to reiterate that I do think we need to get to a level of consistency. We need, in my view, some national standards around this, but we also need to be able to look at how do we do things differently in different areas? How can we have that innovation and good practice? And also, how do we benchmark, not just in Scotland, but nationally, as to where are the really good pockets of things that are being done, and not having standards that are so specific and so rigid that they don't allow us to look at things that would work better in for example, our geography as opposed to in the geography in Glasgow, that there will be quite different needs for the way that we work. So I think there's something about having those national specifications or standards, but not having them tie us down into not doing things well and not doing things properly. I think there's also something about, as been referenced there in terms of workforce planning, we're all doing that in our individual areas and our individual pockets. Again, what's that national look across to say what is the workforce that we need and how do we build that? And how do we build on the existing, but also not just in health, looking at, we have good third sector support from organisations. We work with the Highland Council and Elgin Butte Council. How do we ensure that that workforce plan isn't just about the health component?
And can I ask whether either the Scottish Government at the moment, I suspect the answer is no, or any individual health boards seek to develop a policy for some of the issues like diagnosis recognition that we've heard is extremely patchy responses that people get when they speak to their GP about a diagnosis that's been provided outside the NHS. Do any health boards seek to achieve that kind of consistency at the moment?
Certainly from our perspective, we're not there yet, and it is one of those challenges around that juxtaposition between what we're being given as opposed to what we're providing. So we haven't fixed it, and I don't know whether any of the other health boards have.
unless there's any final comments on that.
Yeah, I was just, I suppose, kind of come in and say, I suppose the difficulty we've got is our services are set up in terms of diagnosis. Diagnosis required to reach support. So there's a fundamental shift and a paradigm shift we need to make away from that towards support being in place and diagnosis being an assessment for that being in place when it's needed and when it's required in order to access the kind of evidence-based treatments that are for ADHD, for example. So a stepped and matched kind of care approach to the waiting list. We have large waiting lists, and it's very difficult to kind of stratify those waiting lists at the moment. It's if we take each person individually. So there's a work around who's on that waiting list and what their needs are, and being able to then direct those in the right direction towards either consensus diagnosis or a more formal structured assessment where it's required. So I think that is what requires the additional capacity. So we can't do that within the capacity we have, but if we had the right workforce, we could work towards that and do that clinical assessment as well as the kind of outreach and the work with our multi-agency partners and education in order to build the kind of supports and the strategies in schools as well.
Can I just check the phrase you used there was consensus diagnosis?
Yeah.
Can you unpack that a little, please?
So that has come through NATE as well as a suggestion, as a way that we could kind of move forward where the family, the young person, the professionals around the table are kind of aware and agree that, say, a young person meets the kind of autism kind of criteria, that at that point, if everyone's in agreement and there's enough evidence, we could give a diagnosis at that point without it needing to go through the SIGN and the NICE guideline based approaches. So I think services have tried to implement SIGN and NICE, but actually they're outdated and it's not possible to deliver that for every child.
And is that approach used for adults at all?
Just wanted to follow up on the point around the transformation programme in Ayrshire and Arran. So for 3 years, really, all partners, whole system, multi-agency across education, social care, children's services, mental health, working together to try to address some of these issues together with the resources that are available. And that conversation about neuroaffirming. So 3 implementation groups were set up in East, South and North Ayrshire. South Ayrshire implemented a panel, a multi-agency panel kind of approach. So some of those ideas were kind of explored. And definitely, I think that's part of the world we need to be more into in terms of changing the culture around. There might be enough information here that could actually, from consensus, reach that kind of approach without going through, more of the complex work that would need to take place. The other thing that Ayrshire and Arran did to enable some of that culture and paradigm shift was invest. The 3 IGJBs invested in a neurodevelopment empowerment strategic team, which is a universal offer to children and adults, drop-in, self-referral, to provide that kind of support, listening, workshops, training, education, information, behaviour support, parental support kind of approach. So that's been instrumental in starting that journey, really, of culture change across our system. But that wouldn't remove the requirement for a formal diagnosis if medication was... So not everybody who's accessed NEST have been able to gain a diagnosis. So NEST is there to support pre- and post-diagnosis. So people will access the service on their journey. And obviously quite a few people, many people are not able or waiting to get a diagnosis. But through that kind of work, feel affirmed and validated and recognised and listened to. Okay. Thank you, Convener.
David Torrance.
Good morning to witnesses. In what way does workforce availability impact on waiting times for neurodevelopment assessments and services, and what impact do long waiting times have on staff motivation and well-being?
Didn't hear the first bit of that question.
In what ways does workforce availability impact on waiting times for neurodevelopment assessment and services?
Significant impact for the areas within Ayrshire and Arran that we have been able to develop a targeted neurocam service. I'll give that example. absolute celebration that we could develop a workforce model, a multi-agency, multidisciplinary team approach, but it's still not enough, and there's still weights, and that creates an issue of burnout within our team. The moral injury of that as well, in terms of not being able to support people the way the clinicians would want to. There's obviously, because people can't get the diagnosis, or it's a long wait, could be 2.5 years. Obviously, we do receive a lot of complaints and inquiries, so the team are dealing with that at the same time. We do have a turnover of staff, unfortunately, so once we've trained our team and the highly skilled practitioners either leave for alternative roles or, unfortunately move to the private sector where the pay and conditions are, come with higher salaries, etc. So we do have that challenge as well. In adult services, I'd say even more of a challenge. In Ayrshire and Arran, we don't have a bespoke service as such for adults. So again, I'm aware of burnout within our teams in terms of not being able to respond in a timely fashion, or being able to accept the referrals. At least 30% of our referrals on a weekly basis to our adult CMHTs of all the referrals that they receive. So it's a high number of people that sometimes we're not able to respond to. So that creates a challenge that impacts on the durability of our staff and morale.
Anyone else? Right, okay.
So, yeah, there were workforce kind of bottlenecks, I suppose, particularly around, you'll have heard, around prescribing. There aren't sufficient kind of medical, non-medical prescribers to meet the demand. So even if we are diagnosing, for example, ADHD, there's still then a wait for that prescribing and their treatment. We have, in terms of the diagnosticians, so that kind of generally sits with a small number of kind of people as well. So we have bottlenecks around the diagnostic kind of process there. As I said, some of these services sit within CAMS, so the workforce may be there, the skills are there, but actually services haven't been able to direct capacity to neurodevelopmental services because of the need to also deliver the mental health weight. So we're kind of confounding two kind of workforces. So I think some of the solutions to this are to kind of better define the workforce, to look at the skills gaps there, to kind of provide some training around that for them. And to have a better skill mix. So we definitely have workforce available through nursing, AHPs and psychology. You'll have heard that as well, who have the skills and the competencies to deliver that and could step into some of these roles if there was a kind of service set up in order to do that. Not only to provide the diagnosis, but also to provide that formulation and understanding of the child and understanding of the neurodevelopmental difference within the context of child development, and to kind of support parenting and education strategies as well.
Thank you. Louise, you want to come in? I can't hear you, Louise.
Is that better?
Yes.
Perfect. Thank you. Apologies. Yeah, the workforce challenge massively impacts on our waiting times, and is the most significant factor to why we have the waiting times we have. Certainly, and again, that is multifaceted. It's not all about us being able to get the people, but it's also having the finances. And as others have said, there's a small market there. There's a small number of people that can actually currently do this, and we need a much greater build-up of workforce, but then we need the finances to be able to do that. So it is a double-edged sword in terms of the workforce. And in terms of the impact more widely, clearly there's an impact on mental health, but there's also an impact everywhere else. So we have people that come into our paediatric services that we haven't yet got a diagnosis for, that we would benefit from in terms of support. There's people coming to our acute services and also in our schools. So the knock-on effect of not having sufficient service and sufficient support staff-wise does cause issues across the system and not just within the core services that cover this area anyway. I think it's also very important to note, and I think somebody mentioned it, around the number of complaints that come in from families. It's often the front door people, so it's folk on reception, folk in admin roles that absolutely get that impact of people contacting them saying what's happening and being understandably very unhappy.
Louise, if you just hold it there, because my next question you will probably be able to answer. What is the impact of short-term or pilot funding on the delivery of service?
So it is really challenging because, as we've already said, the workforce is the number of people that are ready and able to do this role is small, and people want certainty. If there's a substantive job going, then people will go for that much more easily than they'll go for a temporary post. So you're always going to be on an uphill struggle trying to recruit. If there's hundreds of people for one job, then people are much more likely to go for a temporary job. But when it's the other way around, that you've got very, very few people available anyway, they will go for certainty. So that's a real struggle. It's also difficult in terms of planning. If we don't know that the money is going to be coming permanently, we constantly robbing Peter to pay Paul. It's a particular challenge in some. So as a lead agency, we struggle with that being unable to carry money over too. So it's problematic for Highland in particular, but obviously it's difficult for all of the areas. And certainly it also leads to how can you plan a service 5 years down the line if you don't know what the money's going to look like, and you can only really do that almost boom and bust planning. So it is really tricky.
Thank you. Dr. Gill.
Yeah, I mean, I would absolutely agree with Louise in terms of that short-term funding, but it's also where that funding has been directed to. And it needs, if it's coming into health only, then it's not going to support this kind of wider framework we're talking about. It really needs a very different think about how the whole kind of system is funded. It's a multi-agency kind of approach. The funding also needs to go into education and social work and children's services and CAMS in order that we can all kind of provide the bits of that kind of service that we need to for it to kind of hand together and for it to be sustainable. The short-term funding has been very welcome. It's not that it hasn't been, and that the tests of change that have happened in children's services have helped us learn about what to do and what not to do, I would say. But that funding was never about providing the capacity needed. And I think it's that learning from those tests of change, in a kind of whole systems approach that we need in order to know what funding we need and for that not to create siloed working in a way that it has previously.
Yeah, and I absolutely agree. It creates public expectation once you establish a service or an approach, and it usually sits in one part of the system rather than all, as mentioned. And then you might have to retreat from that or take a risk prioritisation approach. So it's and I think the recruitment issues notwithstanding, it's very, very exceptionally difficult to recruit fixed-term posts. So again, there's a risk to take when funding becomes available that is short-term as to whether it's actually viable to go down a certain route. I absolutely agree. This should be looked at as a whole system and what can partners do together in terms of delivering alternative approaches. As you say, always welcome to receive pilot funding and seed funding, but anything longer term, it's that raising expectation to retreat again, which isn't fair on our public and communities.
Thank you. No further questions.
Thank you. Brian Whittle.
Thank you, Convener. Good morning to the panel. Thank you for coming in to give evidence. I've got a few questions around the data. I think we know that the information on sort of waiting lists for neurodevelopmental conditions, assessments and diagnosis is not nationally recorded or published. Can I ask why you think that is and what the impact of not having a full picture has on treatment? Who wants to? Kath.
I think one of the clear reasons for not being able to capture all that data is that assessments and interventions are happening in a number of different settings. So, for example, I'm my service's Tayside Adult Autism Consultancy Team. We cover the whole of Tayside, but not all autism assessments happen within my service. So you asked a question earlier about different models of assessment. So we offer a consultation model where clinicians who are already working with a patient will do the diagnostic workup and borrow our multidisciplinary team to arrive at a diagnostic decision. Or my colleagues in the community mental health team might do some assessments with the clients that they're already working with. So assessments are happening in a range of different settings, and it's really hard to capture that when referrals don't differentiate often in electronic systems what the reason for referral is.
Is it a technical issue we need to look at? Is it you know, do we need to be developing a technical model that allows you to look at the data better? Is that reasonable?
That's one way of doing it. Another thing that we've started doing with our reports is to we've agreed with the GPs in Tayside what coding would be beneficial for them to record after we've done diagnostic assessments, so that we can look at that data. So systems can do that, and it's about looking at how it can be done.
But, you know, if I broaden that out, if we don't have accurate data, we don't have an understanding of the overall issue, then how then does that impact on planning that support and resource and workforce management and understanding the state of play if we don't collect that data, Ms. Bowers?
Absolutely. In Ayrshire and Arran for the last 3 years, hopefully by the end of the year we'll have a business case and a case for change, and one of the first priorities of that programme of work was how do we enable and collate data in such a complex system. In Ayrshire and Arran, that's in our CAMS, adult services, paediatric services, as well as capturing other types of data from our Universal Nest service. So really bringing all partners together to do that. There are technical issues. In CAMS, we have invested in a system which is Power BI, Benson Wintier. It's a workforce planning tool, essentially. So we have confident data in CAMS, and we're building that data set up in other areas. But I think having the standards, the frameworks, and the mandate around this agenda would certainly, I think, drive it forward and make it more of a priority, because absolutely, unless we've got the data and real information about what's happening in our communities, our referral patterns, assessments at every level, then it's difficult to inform what that future should look like and what changes we need to make as a system. Made more complex because, as you say, this is across the whole system.
Yeah, I would agree. I think the challenges have been technical. So my understanding is the health boards have different electronic patient record systems that sometimes make it easy to pull data, sometimes make it more difficult. The waiting lists are held in different parts of the service and system, and are amalgamated collated in the same way. So if the ND service is within CAMS, then that might just be the CAMS waiting list, so how to pull that data out. So there are some technical challenges in terms of pulling that out. But we also know that, so for CAMS, for example, the waiting lists have been split. So some services did split their neurodevelopmental waiting list from their mental health waiting list in order to better report on the mental health, on the CAMS kind of RTT standard. So I think it would be helpful to have some national data reporting to be really clear what it is that you want us to report on and how you want us to report that. And then to beyond that, look at, with each health board, to think about, well, how are they going to do that and how can we do that in a robust way?
Okay. I don't know if Lisa wants to come in on that, maybe just develop on that idea there that sort of neurodevelopmental cases in certain areas, health board areas, are not being disaggregated from CAMS reporting as well, and how that impacts your ability to properly treat these conditions that are exploding at the moment.
Thank you. Can you hear me okay?
Yes, we can.
Super. So just in terms of the data collection nationally, I do think the reason why we perhaps don't currently do it. A is because we've not necessarily all got the systems yet to do it, but also because this has been such a relatively rapid trajectory in terms of waiting lists and referrals. It's not necessarily one of those areas that even 10 years ago we would have necessarily seen something that we needed to look at nationally. So I think that it's becoming, the momentum of the referrals has made it so that we probably, certainly would benefit from looking at it nationally. But I think that's probably the rationale why we haven't to date. In terms of the disaggregation of data, certainly it took us some time to do that. We have done that, and we've done that in both of our areas, in Argyll and Bute and Highland. I think probably, again, it was because as this has become much more of an emerging situation, we've really identified that it's really important to understand our own data and have our own picture. So I don't know if there's many areas that won't have disaggregated or at least started that journey.
Okay, so just as a kind of wrap up here, tell me if I'm assessing this wrongly, but basically across health boards, to get a national picture, we have health boards who record this data in different ways. We'll have a universal platform way of delivering this data. Would that be reasonable to suggest?
Yeah, all different.
And across children and adult services, so it would need to be kind of all age, so that you can think about that transition and the impact and the waiting list kind of curve across kind of children's services and how that will translate into adults as well.
Yeah. So similarly, when developing integrated pathways, you need the data that's coming in through education, and if you're looking at single point of contact, how do you enable collection of that data and transparency of the referral journey. All of that needs to be in a system and a digital kind of way of working.
Okay. Thank you.
Thank you. So moving on to I guess a slightly different topic about lived experience and last week during the committee's session we heard about the underrepresentation of people with neurodevelopmental conditions in planning and delivery of statutory services. So how do NHS boards meaningfully involve autistic people with ADHD in the development of pathways and of services?
So in Ayrshire and Arran, as I mentioned previously, when we started this programme of transformation and reform 3 years ago, we recognised that we need to hear from people with lived experience, children, families, and we invest in our Nest service, which I've already noted, and through that we have regular engagement, at least quarterly. We're gathering information from people with lived experience and how they're accessing services. So we've got a huge amount of information that we've been able to use, and then you said we did. So every time we do that, we seek to make changes in our system. So we've made changes in education by, listening to the feedback from families and creating parent groups, for instance, looking at flexible curriculums and space and how agencies work together within education. So that's just one example. Mm-hmm. But there are many in terms of listening and having that engagement opportunity. I think it's absolutely critical to be able to inform how we can change what we currently have, or we wait to get something better. We need to do that. And through our adult services, which is a particular challenge, when we hear of the experience of trying to access, how can we pick up the support while people are waiting, or if there aren't any alternatives for them at that point. We also have experience through our occupational health department as well. Obviously, we've got a workforce that are also obviously neurodiverse, so it's really understanding the impact across our whole system, and we're doing that across the whole of Ayrshire.
So you talked there about this. You said we did model of adapting services and responding to the feedback that you get. But in terms of developing services and developing pathways, how do you involve that community?
Yep. So I think looking at when we've so through this case for change that we've been developing over the last few years, and we hope to have some options that we can obviously cost and look at the feasibility. That's where really then through that network, we've got a mental health network as well, from an engagement perspective, that we would then involve in developing the options and building on them. And that experience then would be captured within our case for change. So that, I think, truly represents listening to our communities to develop what those alternative approaches should look like.
And do you think that's enough? Because it sounds like at last week's committee meeting...
No, I don't think it's enough by any means. I don't think it's enough by any means, but I think listening to our experience... obviously, we've noted the complaints and seeking to improve the quality of what we do at every level. But I agree there's so much more we need to do as a society, notwithstanding within our health provision and social care and education.
Anyone else? Kath?
Yeah, I was just going to say I was really pleased that third sector and voluntary organisations came first in this conversation, because that represents absolutely how it should be. We've just appointed 2 peer support workers, so we've got a test of change and collaboration with Scottish Autism, who were represented last week, and they're employed by Scottish Autism, but they will sit within the autism assessment team. And the idea is to have genuine co-production and co-facilitation of some of the provision that we've got. So that's one way of valuing as colleagues our neurodivergent population. And another example was when the neurodevelopmental pathway redesign was beginning in Tayside, and all stakeholders were around the table there. So it was service user organisations, social care, carers, other statutory services, and that has been a process of genuine co-production. The collaboration with Scottish Autism has also offered resource for patients on our waiting list. So it's definitely an unmet need in all areas. I think people who don't have a diagnosis or who decide not to go through a diagnostic process. So Dundee Connections offers that resource for people. So that very much service user led and service user provided resource for people. So essential and can be done really well. And I think that's the move forward to better involve third sector as equal and collaborative partners.
And it's perhaps easier to do some of that work with adults. So how are you involving children in developing services?
I shall hand over to my children colleagues, as I work exclusively with adults.
There's likely a thing that we need to be doing it better, but there are areas of good practice and examples of good practice, particularly with families. So with kind of parents where so some of the tests of change that happened around the neurodevelopmental pathways had reference groups where parents were involved in being able to kind of shape the development of the resources and of the referral pathways coming in.
I get that the adults get involved with developing adult services and children's services, but I'm particularly keen to know how we involve children and young people in those.
So here in the Child's Voice is something we have been working on with our AHP colleagues around speech and language therapists on training staff in the use of talking mats, which you may have heard about as an accessible visual way of trying to have a conversation with children, particularly neurodiverse children who might find it more difficult to put things into words. So being supported with concrete visuals can be a helpful way of hearing their voice and having their input. So there are kind of approaches that we know that are possible to deliver and accessible for children. So where we're not doing that, that's something we can build on, and we can work with our colleagues in speech and language therapy to kind of train the workforce in delivering that. And we have done that within NHS Lothian CAM service. We're using that approach to try and hear the child's voice more in terms of that feedback after assessment, before assessment, and while they're waiting.
Louise, I don't know if you want to come in on this point.
I do, absolutely, thank you. And I think it is definitely an area we need to do more on, but I think it's because it's tricky, we've got to work out how to do it differently. Certainly within Highland, obviously we have the, as I mentioned before, the lead agency model, so the majority of our children's services sit within the Highland Council for health, and they've got quite strong links to how their children's plan was developed, and we had a number of co-produced pieces of work around that, particularly using third sector organisations as support, and we're trying to almost piggyback on the back of that a little bit with the new plans that we've got for a co-produced piece of work with the Highland Council, with health and with children and families. As others said, it's not easy, and we're still at a fairly early stage of that. And I think if anybody's got this fixed, it would be another really good area for us to benchmark across boards and say, how have you managed to achieve that well? Because I think we're all grappling with it a little bit.
Thank you. Emma Harper.
Thanks, Commissioner. I'm just thinking about referral processes. In our briefing papers, it mentions where we took evidence last week that the Royal College of Speech and Language Therapists reference the use of open referral, and they are citing examples of Fife and Dumfries and Galloway, which both have strong speech and language therapy representation in pathway leadership teams, and they cited them as excellent examples of good multidisciplinary collaboration. So I'm interested to hear about the advantages or disadvantages of open referral in neurodevelopment, diagnosis and assessment and support.
So I think the worry has always been with open referrals is the volume of referrals that will come through. And I think along with the aligning with the idea that we don't have good data collectively about any areas of pathway within neurodevelopmental services, it's hard to know if that's the case. I think Grampian's been cited as an example of adult services where there's an open referral. I would want to see better information about what the processes are post self-referral as well. So consistent referral pathways for us to identify how we're better triaging those referrals. So, for example, there was a study done earlier on this year that looked to assess patients who were rejected from an autism assessment service, and all of those patients were given a full diagnostic assessment, and none of those met diagnostic criterion. So appropriate triage means that the right people are getting assessments in a more timely way. So my concern about open referral is the volume of referrals that come in even when there's a criterion. But that's not well evidenced, so we need better evidence around that, but also know that there's good evidence that suggests triage processes target assessments in the right area.
Okay. I suppose I'm wondering if you could have both. So the open referral is really for that request for assistance, for support, and for understanding and for strategies. And absolutely, I think that is something that is in some areas a new way of working that we can kind of build and spread and expand. But going back to the point about that stepped and matched care, so that is needed at the point where parents and education are requesting that support. So easy access for that would reduce the need for referrals in for a diagnosis when actually that's not the requirement. But also we do need a way of stepping up those requests where a diagnosis and a formal assessment is required. And I think Fife are working that kind of model where they have that open access for support, but there's also the mechanism to refer in when further assessment is required and kind of needed. And that decision is based not on a health basis, but is done in a multi-agency way and is done in combination with health and education kind of professionals, and can also kind of fit alongside approaches like the consensus diagnostic approach, and also that stepping up to where you need more medicalised kind of assessment. So I think it's not either or, it's kind of both, but the challenge is how do we resource that, and how do we have the systems in place in order for that to happen in a kind of smooth way.
And in Ayrshire and Arran, we're looking at, for children at least, a single point of contact, working with education, primary care and children's services. We're looking at digital solutions maybe to do some of that work. Again, the same in terms of a kind of a stepped approach, looking at the request for support approach and being able to channel that within the school or within Nest and other supports that might be available at third sector, and then the triage approach with CAMS. But we've got a family support service as well that the IJB has invested in, which children with neurodiverse needs can be referred into that service. So at the moment we're trying to build that pathway. I wouldn't say we're at the point of open referral. It's looking at, can we develop a single point of contact and be sure about how we're resourcing and navigating the referrals as they come in through that process. That would probably be at a much later stage, but I think quite resource dependent because of the significant volume of referrals that may precipitate.
And the referrals are normally coming from teachers or GPs, practices?
Yeah, so it's split between the two, education and GPs.
Right. And so does more work need to be done to support these perceived gatekeepers to, I suppose, raise awareness of ADHD and autism and actually how people can have both? And how do we... I mean, I like the language Patrick Harvey used in the previous session, was to talk about more neuro-affirming language so that people who are working in the public sector have more knowledge, more ability to listen and learn, actually. And locally, for us in Dumfries and Galloway, there's a group, Sleeping Giants, who did a consultation called Think Differently, which was conducted. They did about 186 surveys of people to help them get support, for instance. And it was really, really well written. It was really well done. And now they're taking forward the recommendations. And part of that is about awareness raising for the wider public sector.
Yeah, absolutely. And as I mentioned earlier, we've got our Nest service that does a lot of that work in terms of training and education. And all of our partners are on this programme of change and reform together. So there's still quite a lot more we need to do around how we build that pathway that I described and the options that we're looking at for service models, and how we can phase our approach to get towards a better future, if you like. But how we work better with what we've got currently is what we're trying to really develop. And I think you wanted to come in there as well.
I was just thinking about the competency frameworks that kind of fits with what we were saying about the need for that overall framework as to what skills people need at different levels. So what do you need at a universal level, at a skilled level? What does your football coach need? What does the receptionist need? And how do we share the kind of neuroaffirming language and approaches and kind of strategies at that level right through to what you need if you're diagnosing and kind of doing specialist assessment? But the neuroaffirming language is also kind of that public health approach. How do we write reports? How does the government write reports in a neuroaffirming way? How do we shift the language that's used so it becomes the language that everybody uses? And that then is neuroaffirming and supportive of kind of people at every level. It's also thinking about the environmental adaptations that we need. It's not only about language and communication, it's about how our buildings are set up, how we're providing information for people with autism and ADHD to know how to manage those areas. So where will you where's the sensory overload and where can I go to kind of reduce that. So we might not be able to change the fabric of our buildings, but we can certainly communicate and share how to best navigate that for people that are neurodiverse. And that's something that everybody, you know, all of us could benefit from as well. And there are some good examples of sensory maps. And if you go to Edinburgh Zoo, there's a sensory map that helps to signpost families and children as to where the busy areas are going to be, where the quiet areas will be. So giving people some control over how to manage the environment that they're going into and to know what to expect of those environments so they can prepare ahead of it. So it's really understanding, seeing the world through a kind of autistic kind of lens, and then thinking about, well, how do we build those supports into kind of a fabric of society, really?
And even just giving people actually that heads up that yes, there's a quiet space, yes, there's a different place that you can go, can actually help be quite affirming anyway if somebody has
I mean, it's also affirming if you're anxious, but if you have difficulties in imagining what a place is going to look like and holding in mind what that room's going to look like when I go into it, that creates an anxiety. But if we can provide information or videos, you have some good information for coming here about, you know, what the pictures are, you know, video walk-arounds, then that helps somebody prepare. I'm going to go into that place. I know what it looks like. I know where I'm going to sit. I know what the lighting is going to be like. Then I can have my own coping strategies to kind of manage that. You know, then that. It also helps people who are anxious but not neurodiverse. It helps everybody, so they're not disadvantaging, you know, people that are neurotypical, but equally very supportive for people that have neurodevelopmental differences.
Okay, right. Yeah, I was conscious that Louise hasn't spoke.
Thank you very much. And I think a fair amount of the points that I was going to make have been covered by other people anyway, so I'm not going to elaborate much more. But I think one of the challenges of self-referrals, as people have said, is setting expectations when we haven't necessarily got something there sufficiently to support people. So I think we need to do the building work with people, but the building work as to what services should and could look like, get them into a better place before we look at too much self-referral, because I do worry that people would be expecting something that we can't provide unless there's that interim arrangement, as people have referenced, in terms of support. I think there's also something about working with our existing referrers to make sure that people are being referred to the right place, and that we've got that package across systems working and not just all referrals to one source. Certainly we've noticed there's a huge spike in our referral rates just before the summer holidays. Certainly the last 2 years, we've got an enormous spike at that period of time. And there's something about how are we working with people throughout the year to make sure that the services, and for example, in schools, that children are already getting a level of support that's right for them whilst they're waiting as well. So there's something about making sure that the referrers know where they're referring to, what they're referring to, and what those pathways are.
Okay, thank you. Thanks. Elena Whittam.
Convener, and the last part that Louise just mentioned actually segues into the questions that I had round about resources and information when people are awaiting assessment, or they're actually perhaps even awaiting the kind of triage that might happen at that point. I think that all of us as parliamentarians have had a lot of inquiries to ourselves from constituents round about needing a co-occurring mental health concern actually to even get access to some of the lists at the moment, or lists that aren't there. So how do we ensure that people can wait well during that period and that they have access to all of the information that they need? And how do we ensure that when you are on that waiting pathway, that you are informed of what's going to happen at every single stage of that journey? Because sometimes things land out the blue. We heard that last week. And, you know, you're given a couple of days to fill in these massive questionnaires that you need to get back, and then you don't hear anything for a year. And that can feel really quite isolating. So it's about how do we ensure that those resources are up to date, the information is up to date and clear and helpful. I think if we look at NHS Inform just now, ADHD is under mental health and autism's under brain conditions, and you really wouldn't think to look there if you were actually trying to find information. So how do we ensure all that as well?
I think it's really important that there is a focus as a priority on that information, and I'm giving again the example in Ayrshire and Arran of Nest. So the IJBs recognise this. We're making changes within our system. People are not able to get diagnosis. How do we inform people? How do we offer alternatives? The training aspect is really important. So in Ayrshire and Arran, that's why there was that investment in Nest, which was quite a central point, building the website, creating information that is accessible, having that ability to contact the service. So Nest can be a central point for that, as well as being able to contact the service for information about weights. Nest is linked into all of our statutory services as well as our wider partner agencies, so quite pivotal in being able to flag if there's an issue. We have also invested in waiting list initiatives. So for children, we certainly have worked with the third and independent sector to create alternative supports and options like physical activities and programmes of therapy while young people are waiting on the wait list. So that's something else that we will continue to explore and learn from, and we've done that across Ayrshire and Arran. So those are good examples. Apps as well, we're investing in apps. I think that's another good way of keeping people up to speed.
To get information to people
yeah.
that's easily accessible at a time that they want to access it in an easy
Yeah.
format. Does anybody else have any? Yep, Kath?
I think this goes back to the issue that's been mentioned a few times of whole-scale change already, because the children's specification indicates that it should be needs-led, and nobody has disagreed with the fact that services should be needs-led. However, they're not. So what we need to do is really provide wider services with the skills to work with neurodivergent people. People with neurodevelopmental conditions and neurodivergent people are overrepresented in a range of health services. So in terms of kind of waiting well, what are people waiting for? And why can't services that are already involved with that person support that? So I think it's an aspiration that people are all wanting to work towards in terms of that whole-scale change. It seems unachievable. That's always been the but. We should be working towards somebody's needs, but there isn't the resource there. We still need to move towards it. So that waiting well involves the whole-scale change as well as provision for people while they're on the waiting list. And the outcome should be increase in quality of life, not just necessarily a diagnostic assessment.
Yeah, because I think what is concerning us in terms of why this inquiry has come forward is the fact that people tend to tip into mental ill health while they're waiting because they can't get, can't get access to services, or they're perhaps in the criminal justice system, or they're dealing with, substance use issues, and there's been a clear gap in actually understanding what's happening for that person. So absolutely, it's about that whole systems approach and that whole systems change. And I'm glad that we heard the third sector mentioned, because I think that this is a real key area where we need to figure out how do we empower them, resource them to actually do a lot of the scaffolding, I suppose, that's needed underneath families and individuals in that circumstance.
So I was thinking about Once for Scotland policies from a kind of health point of view. We have areas of good practice. We can bring those together and have something that's consistent at a national level and at a public health level. So there are some workshops, interventions for kind of parents that could be delivered at scale online, and that could be delivered nationally, so it would help with the kind of very rural areas and the urban areas. And parents can access that, they can book onto that without a need for a diagnosis that could be easily accessible. I think rather than that being recorded, that can be delivered by skilled professionals who have the ND expertise. So you're using the workforce in a scaled up way. So that's at a kind of national level and should be at a universal level. And then below that, at a local level, you have that more ability for parents and education to kind of get that individual information about a child and that kind of formulation and that understanding about their vulnerabilities, but also what are the things that are maintaining their kind of current difficulties. So I think it's about those kind of national, local, kind of individual level, and having that kind of across the kind of age range. And there was something else, but I've gone out of my mind.
I'll just briefly bring Louise in terms of, from a Highland perspective, I think that Jill just really put context around about that in terms of the rurality that you're facing and what can be delivered online. I don't know if you have any other thoughts.
Yeah, absolutely, and certainly we do make very good use of online for obvious reasons, but equally there are people that struggle with online, particularly for assessments and dedicated work. So we have to be flexible and try and offer both wherever we can. Certainly we have a fabulous autism initiatives third sector that we work with very closely, that provide a lot of support for people, be that one-to-one, be that groups, be that online activities, etc. So there is very much that reliance on the whole picture and not just on us trying to support people to wait well, which at best is limited.
Can I just come in again around just general understanding about child development and the change in, that we know children are, the context of what they're living in at the moment, and access to kind of screens, the impact of COVID on their social communication and kind of development. And I think we can't ignore that, and the need to research that and understand that and feed that into the early intervention for the kind of younger children, to ensure that we're kind of maximising the opportunities that for kind of developing their social emotional skills as well.
Yeah, and I suppose in all of that there's a role about how that new kind of world that we work in aids and abets masking or doesn't, and how those different things affect individuals who maybe would have went their whole life without actually developing an issue, but the world we live in now creates that.
And how that might be more difficult to move away from if you're neurodiverse.
Yeah, absolutely. Oh, I was going to hand back, but
it was only a small point. It was just to add, while people are waiting on waiting lists, there should be robust approaches around escalation points, because of people's needs change, obviously, while they're waiting, especially children. So that's really important as well in terms of risk management of all waiting lists. In terms of children, certainly that are not able to access CAMS, we also provide in-reach kind of approaches into the settings like education from a CAMS perspective to support young people and really, again, escalate risk as that emerges.
Thank you.
Thank you. Can I thank the panel for their evidence this morning? At our next meeting on Tuesday the 28th of October, the committee will conclude oral evidence as part of its inquiry into ADHD and ASD pathways and support with the Minister for Social Care and Mental Wellbeing, and that concludes the public part of our meeting today.